The focus of Module 2 for PGE is about planning models and also needs analysis, which is the very beginning of starting any program, service, and project. And there will be four different recordings. One is a planning model covering substitution and demand management, and there will be another video on prevention program planning. Then we have a video on needs analysis, and then the last video we looked at aims, objectives, and strategies. That are those fundamental components of any program, service, and project, and to discuss what they are. In Module 1, I have shown you this diagram and really basic service delivery model. So you get at the top, we will have needs of the population to be addressed, or we have problems to solve. And when people have needs, it doesn't mean that they will come to the services. There must be reasons that they present to the service. For example, they may have diabetes, they may have high blood pressure, but only when they experience complication or turn into acute episode, they might come to emergency department, or they go to the general practitioners, ask for support and services. So there's many factors that will impact on whether consumers and patients are coming to seek for services, including some people, they have the needs, but they don't believe that the needs need to be addressed, or they don't think the services are appropriate for them to receive. So there's sort of reasons we need to understand. So when they come to the services, then the service, we have two factors. One is the capacity of the service that we can provide to the patients, and also the level of utilization of the patient of the services. That balanced by, when we design the service capacity, have we considered all the needs that we currently identify? So, for example, if your organization have data indicating the types of number of patients requesting the services or in need of the services, then we design a new service to meet the needs without considering there are still people in the community have similar symptoms of diseases, but they're not aware of their needs for services or for treatment, for intervention. So we call them latent needs. So when the service become available, if we didn't take latent need into consideration, and those people, when the service is available, those people realize that they are actually in need of those services, the service will be out of capacities. So when we design the service, we need to consider both needs. So the best scenario will be the express needs equal plus latent needs will be equal to the service full capacity. And when we build promotion strategies or marketing strategies into the services, in promoting services, we can, in a short time, when the service become available, we can reach 100% utilization that match the capacity. That's the best scenario. But if this is not the case, for example, if the service capacity do not only meet the demand of express needs rather than latent needs, that will create waiting. Then will impact all. If we have services without effective marketing and promotion strategies, that will not have full service utilization. But whatever it is, as long as the service, as long as the utilization service, there will be outcomes created as a result of the service, and then by the end, then we'll reduce the needs to be addressed. So this is the basic service model. So let's have a look at how we fit a scenario into that service provisional model. That's the case. There has been 10% increase in admissions to the local hospitals in Wonderland City Council area, so just WAHCA, due to acute episodes of high blood pressure amongst those aged between 45 and 64 who may or may not have been on high blood pressure treatment. So if the trend persists, the hospital will not have the capacity to deal with the increased patients in a timely manner. And the possible reasons for increased acute episodes of high blood pressure are listed here, such as drug abuse, high fat content, smoking, anxiety and stress over use of stimulating drinks, or other unidentified medical conditions. So let's look at the service model diagram. We added 6 factors. So these are the 6 factors here, or the reasons here. So these 6 reasons led to the increase of acute episodes of high blood pressure among the population aged 45 and 65. So this is the box in the original service delivery as population needs. The reason that they are seeking the services suddenly come to the hospital for services is the acute episodes that presented to these populations. If in this case if we have 100 cases presenting the hospitals and there's no other cases that did not present, means all acute episodes have been presented, so latent needs 0 and express is 100. If no one else will be developing acute episode, if this scenario, then we will say the acute service output will be 100. So if we can deal with the 100 cases when in present to the hospital, then the waiting list will be 0. So that matching the full capacity of the services and the full utilization of services. So the outcome will be there's no mortality. 30% of those people admitted to the ER will be hospitalized, and 70% fully controlled after ER intervention. So then that will reduce the high blood pressure demands. However, the service itself does not address the 6 factors that actually attributed to the acute episodes. That means the need for emergency services for acute episodes still exists in the future. So if we're not addressing the causative factors, the 6 factors, so we can predict there will be increased demand, 10% demand or 20% demand in acute episode of the emergency department services due to the increased acute episodes. Say if the express needs become 120 other than 100, and we're not sure about the latent needs at the moment because there's an increased trend, and the full capacity of the ER to deal with the patients 100, that create 20 out of 120 waiting. So what the outcome is, if acute episodes not treated immediately, that will have adverse consequences. So the outcome could be possibility of mortality. We still have 30% hospitalization, and we're not sure about now the 70% fully controlled episode after ER, because we have got long waitings, and then because of the 20% waiting, then there will be a percentage of the cases develop into complication due to delayed treatments. So there's the 2 scenarios of when the demands of the services meet the full, that can be fully addressed by the service capacity, or when the demand of services are larger than the full capacity of service provision, then we have adverse consequences. So for this case, then we need to do something about this. Firstly, we need to reduce the demand for the ER services. We need to reverse the increased trend in developing acute episodes among people with high blood pressure, with or without treatment. Okay. Before we decided to increase the capacity of the emergency department, because this is one of the most expensive interventions or investment. So this is comprehensive planning models You can see on the top is really similar to the service model that provided, but for full planning model, we need to take into consideration of the causative factors, needs of the population, factors mediating service seeking, in consideration the level expressed need and the latent need. Then we design the service, and we in consideration of the utilization of service versus the weighting that we create, because the gap between service capacity and the demand of services. When we want to reduce, before we increase the service provision, or expensive service provision, we can consider 3 other approaches which create long-term benefits as well, that will ultimately reduce the needs of the populations, which is substitution with direct demand management and prevention program. They may not immediately reduce the demands of the services, however, the investment can go a long way and is much cheaper than provide tertiary and services in the hospital system. And now I would like to talk about substitution. Substitution refers to innovative ways, less expensive ways, new ways of using additional resources and to address the needs of the population. So if you have increased demand of the ER or other expensive services, instead of investing resources in increasing the amount of services to provide, but we adopt innovative ways in addressing those needs. So we call that substitution. So we address the expressed needs in a different ways, and we contribute to the service utilization in another form, and then we produce outcomes and reduce the needs of the population to the existing expensive services. So this is how it looks like. So you still have service provision, expensive service provision. At the same time, you're providing innovative way of services in supplement of current services, then produce outcome and then balance the needs to be addressed. Example, so what is substitution? Substitution aims to produce high quality experience and a greater consumer outcome and less costly intervention and treatment. So that's efficiency gain. We address the expressed needs, restorative and maintenance outcomes, and we deliver a better service delivery strategies. Some example could be the introduction of hospital in the home program. So instead of encouraging patients to be hospitalized, we provide services at the home, such as the nursing hotlines. Instead, we provide nursing hotlines, so some of the patients, instead of going to see GP or going to the ER, some of the symptoms can be diagnosed and receive advice, and then they could be some self-medications or self-care can be performed to reduce the demand of extra services, such as community aged care packages. Instead of sending elderly people to the residential care, they can be cared at their own home. So another model of service planning is demand management. Demand management is designed to address factors mediating the service seeking. By doing so, it will create outcomes and then eventually address the needs to expensive services. Of course, all those, both substitution and demand management, will require resources to implement. However, it's less costly and it could create long-term benefits. So if you capture the model out from the diagram, that's what it looks like. We address the factors mediating seeking through the program, generate outcomes and reduce the demand of services. So demand management address both supply and demand. So we address the demand for services. At the same time, we address the demand for accessing those services and demand for providing those services. We focus on unmet demand, also such as the latent need, such as inappropriate waiting, following the express need because service out of its capacity, and the equity of unmet need, and prioritizing access to services. So you might have the service, for example, the triage system is an example of prioritizing access to the ER. So patients in urgent needs of being seen by the doctor will be seen by the doctor first. And the changes will focus on factors mediating service seeking, such as we are changing individuals' consumers' attitudes about healthcare, their personal habits, self-efficacy, and self-advocacy. This is an example of demand management strategies. It's such as introducing explicit eligibility and entitlement criteria to prioritizing access to services, so that people in urgent need of services can be serviced first. Introduce triage system to manage access time, priority order, and target efficiency. To improve service efficiency, to increase utilization capacity. And consider early intervention and prevention strategies in combination to reduce the need and demand for services. And to increase resources, to increase service utilization capacity. Using demand management for chronic disease control, we can see that it can lower the incidence and severity. That's the focus. For example, remove barriers to recommended routine prevention care services, provide decision-making support to build self-efficacy skills, employ levers to drive desired behaviors. For example, they take full control and responsibility for better diets and more active physical activities, and develop a comprehensive worksite wellness programs that actually can reduce potential demand for future services, create transparency, and motivate employees to care about the cost and quality. So this is just the examples of demand management for chronic disease control. Also, example could be introduce integrated disease management for patients with established disease, such as referral, coordination, and substitution. Introduce standardized risk assessment, care planning, and early intervention for at-risk consumers and those with early comorbid conditions or early disease. So these are examples of disease demand management. The key message is, regardless what time the services is, when we consider increasing expensive tertiary interventions or hospital-based services, we should consider innovative ways in addressing the demands for these expensive services using adopting demand management strategies and substitutions concept. And also later on, we will talk about prevention programs in addressing the needs of the population, the express needs, and also the factors mediating service seeking, and also the cost effective. That's we talk about prevention program.